Welcome to the Hospital Medicine Unplugged podcast. Today, we are undertaking a critical exploration into a high-stakes clinical entity that really demands our absolute utmost vigilance on the wards and in the clinic. We're doing a deep dive into Brugada syndrome.
Yeah, and we are basing this discussion on the latest clinical management strategies, the recent JCC-focused seminars on precision medicine approaches to cardiac arrhythmias, and of course the comprehensive AHA, ACC, and HRS guidelines.
Right. And for you, the clinician on the front lines, whether you are a hospitalist, an emergency physician, or a primary care provider, navigating the dense medical literature surrounding this condition can be, well, it can be a daunting task.
It absolutely can. The literature is dense, and it's constantly evolving.
Exactly. So our mission today is to cut directly through that complexity. We are here to extract the critical, life-saving knowledge you need regarding how to accurately diagnose, rigorously risk stratify, and effectively manage patients presenting with Brugada syndrome.
Because the clinical relevance of this topic, it truly cannot be overstated. Brugada syndrome operates as a true chameleon within the realm of cardiac electrophysiology.
A chameleon. I like that description.
It really is. It is a condition that can seamlessly hide in plain sight, maintaining a completely normal baseline appearance on standard testing, only to be suddenly and, quite frankly, catastrophically unmasked by seemingly benign everyday occurrences.
Everyday occurrences, right. Things you wouldn't normally think twice about.
Exactly. For you, as the attending physician or the inpatient specialist, understanding this syndrome is far from a mere academic exercise in pattern recognition. It is fundamentally about recognizing a dynamic, sudden threat to your patient's life.
Because the underlying substrate is so volatile.
Precisely. The underlying genetic architecture and the resulting pathophysiology create a myocardial substrate that is exquisitely sensitive to external variables. Therefore, mastering the nuances of this condition is paramount for preventing sudden cardiac death in vulnerable individuals who might otherwise appear perfectly healthy.
Okay, let's unpack this. We must begin with the cornerstone of our clinical assessment, which is the electrocardiographic recognition of the syndrome. Historically, there has been considerable ambiguity regarding what actually constitutes a definitive diagnosis.
There has been a lot of debate over the years, yes.
But the current diagnostic benchmark is incredibly specific and rigid now. The only truly diagnostic ECG presentation is the type 1 Brugada pattern. The exact criteria are non-negotiable.
Right, you have to know exactly what you're looking for.
When you are looking at the 12-lead ECG, you must observe a coved ST segment elevation of at least 2 millimeters in one or more right precordial leads. We are specifically talking about leads V1 through V3. Furthermore, this coved elevation must be immediately followed by a negative T wave.
That morphology is key.
Recognizing this specific, distinct morphological signature is the absolute prerequisite for diagnosis. But, why just those specific leads? What is it about V1 through V3 that makes them the window into this disease?
That is the crucial physiological question. Leads V1 through V3 are anatomically positioned to look directly at the right ventricular outflow tract, or the RVOT.
The RVOT.
Right. The RVOT is the embryological and electrophysiological epicenter of Brugada syndrome. The structural and functional abnormalities, specifically the reduction in the sodium channel function and the resulting transmural dispersion of repolarization, are highly localized to the epicardial surface of this specific region of the right ventricle.
So it's incredibly focal.
Highly focal. Therefore, the electrical footprint of this disease is projected anteriorly and to the right, landing squarely in the territory of V1, V2, and V3. If you're not scrutinizing those specific leads, you will miss the diagnosis entirely.
And it is vital to trace the evolution of how we interpret that signature. A monumental shift occurred with the 2013 expert consensus.
Oh, absolutely. That was a paradigm shift. Prior to that, the clinical community often hesitated. We required the presence of additional clinical manifestations, such as a documented history of arrhythmias or specific symptoms, to definitively lock in the diagnosis, even if that type 1 ECG pattern was glaringly present.
Right. The old criteria essentially forced clinicians to wait for something bad to happen before they could confidently put the Brugada label on a patient's chart.
Exactly. You had to wait for the clinical event.
Yeah.
But the 2013 consensus decisively redefined the diagnostic criteria to mandate only the presence of this type 1 pattern in the right precordial leads.
Just the ECG finding.
Just the ECG. It does not matter whether this pattern is occurring spontaneously while the patient is simply lying in the bed, or if it has been drug-induced during a formal pharmacological challenge in the electrophysiology lab. The requirement for accompanying clinical symptoms was completely removed from the primary diagnostic criteria.
That's a massive change for clinical practice.
It is. The rationale behind this shift is profound and directly impacts your daily practice. By decoupling the diagnostic ECG pattern from the requirement of clinical symptoms, the cardiovascular community acknowledged a terrifying reality. Waiting for a symptom to manifest in a disease whose very first symptom can be sudden cardiac death is an inherently flawed, highly dangerous strategy.
The first symptom is often the last symptom.
Exactly. The substrate itself, evidenced by the type 1 pattern, defines the syndrome.
This brings us to a crucial point of differentiation that often confounds inpatient teams, especially during cross-cover situations or late-night admissions. We have the strictly diagnostic type 1 pattern, but we also frequently encounter the type 2 pattern, which is often referred to in the literature as the saddleback morphology.
Yes, the saddleback. You see this a lot.
You do. The criteria for type 2 involve an ST segment elevation of greater than or equal to 0.5 millimeters. But unlike the sharp coved shape of type 1, type 2 presents with a convex ST segment, which dips down like a saddle and is then followed by a positive T wave.
And that positive T wave is a key differentiator.
It is imperative for you, as the evaluating physician, to understand that the type 2 pattern, as well as the occasionally discussed type 3 pattern, are merely suggestive of Brugada syndrome. They are not diagnostic in isolation.
That's right. They're clues, not confirmations.
If you see a type 2 pattern, it should raise your antenna, but it does not buy the patient a definitive diagnosis on the spot.
What's fascinating here is the sheer dynamic nature of these electrocardiographic findings, and this is where the true clinical peril lies for the hospitalist. These suggestive or even diagnostic patterns are not static features permanently etched onto the patient's resting ECG.
They fluctuate
Wildly. They can be highly intermittent. They can completely vanish, rendering a standard 12-lead ECG entirely unremarkable, only to reappear hours or days later.
which makes screening incredibly difficult.
Exactly. The variables that unmask these hidden patterns are remarkably common in the inpatient setting. We see these patterns unmasked by states of high vagal tone. Think about a patient who is resting deeply or sleeping, their vagal tone surges, and suddenly the type 1 pattern emerges on the telemetry monitor.
The sleeping patient scenario is classic.
It is. We also see it unmasked by the physiological changes occurring in post-prandial states after a heavy meal. We see it triggered by the introduction of specific medications and, critically, by physiological stressors. This extreme volatility demands a fundamental shift in how we monitor these individuals on the wards.
It is entirely akin to a clinical form of invisible ink. Imagine looking at a patient's chart and their admission ECG. You see absolutely nothing concerning. The paper appears blank, the rhythm is sinus, the ST segments are isoelectric.
Nothing to catch your eye.
Right, but the underlying lethal potential is written right there in the myocardial tissue of the RVOT, waiting for the precise chemical or physiological reagent to make it visible. This is exactly why inpatient medical teams must maintain an incredibly high index of suspicion and an exceptional level of vigilance.
A single normal ECG means very little.
A single, isolated, normal ECG in the emergency department does not clear the patient if the clinical story is suspicious. When dealing with the suspected Brugada case, continuous telemetry monitoring and serial ECGs, particularly during changes in the patient's clinical state, during febrile episodes, or after the administration of new medications, are an absolute necessity. You are actively hunting for these fleeting, life-threatening changes.
Transitioning from identification to action requires us to navigate the most challenging domain of Brugada management, which is risk stratification. Determining who is actually at imminent risk of a terminal event is the essential calculus we must perform to determine candidacy for an implantable cardioverter defibrillator, or ICD.
The stakes are incredibly high here.
This is a high-stakes mathematical exercise. We stratify these patients into distinct tiers of danger, beginning with the high-risk category, which universally carries a Class I indication for ICD placement in the guidelines. The criteria here are unambiguous.
These are the patients who have already shown us what their hearts can do.
Exactly. Patients with a prior cardiac arrest, or those with a documented sustained ventricular arrhythmia, are naturally at the absolute apex of risk. They have already proven their myocardium is capable of lethal instability. However, the critical third pillar of this high-risk tier is the combination of a spontaneous type 1 ECG pattern with a recent occurrence of syncope that is presumed to be due to a ventricular arrhythmia.
Let me stop you there and focus deeply on that word, syncope, because for the clinician taking the history, differentiating the cause of a transient loss of consciousness is notoriously difficult. A 25-year-old patient tells you they passed out. Was it a vasovagal reaction because they saw a needle? Was it orthostatic hypotension because they were dehydrated? Or was it an aborted episode of polymorphic ventricular tachycardia?
That is the central diagnostic dilemma we face every day. When the guidelines refer to syncope in the context of Brugada high-risk criteria, they specifically mean arrhythmogenic syncope. You have to interrogate the history aggressively.
What specifically are you asking them?
Did it happen suddenly without a prodrome? Did it occur while the patient was supine or at rest, rather than upon standing? Was there a lack of typical vagal triggers like heat, pain, or emotional distress? If the syncope lacks a clear, benign explanation and occurs in a patient with a spontaneous type 1 pattern, you must presume it was a self-terminating ventricular arrhythmia.
You have to assume the worst.
You do. And when we look at the longitudinal data for these symptomatic patients, the numbers are stark. They face an alarming 5 to 10% annual event rate. That means every single year, they carry up to a 1 in 10 chance of sudden cardiac death. That is a massive compounding risk year over year for these individuals.
That isolated clinical event, the syncope, is the absolute pivot point in our risk algorithm. We must contrast that 5 to 10% annual risk in the symptomatic high-risk group with the parameters defining the intermediate risk category. Let us break down the intermediate tier carefully.
It's a very different statistical picture.
It is. If you have a patient with a spontaneous type 1 pattern, but they are entirely devoid of symptoms, no history of cardiac arrest, no arrhythmias, and absolutely no history of syncope, their annual event rate drops precipitously to between 0.5 and 1.2%. It is still a risk, but it is an order of magnitude lower.
Right. They are managing the substrate without overt instability.
However, the moment that same patient with that same spontaneous type 1 pattern experiences a single episode of syncope, the risk profile violently shifts. The event rate surges to an estimated 6 to 19% over a comparatively short 24 to 39-month period. The presence of a single sudden loss of consciousness drastically reconfigures the mathematical reality of survival for your patient.
Furthermore, the guidelines highlight an additional nuance within this intermediate tier. A type 1 ECG pattern that is specifically induced by a fever, even in the absence of syncope, also falls into this intermediate risk classification.
Because the fever acts as a profound stressor.
Exactly. The physiological stress of the fever reveals a severe vulnerability in the sodium channels that warrants heightened concern. Now, to complete the risk stratification spectrum, we must define the low-risk category. This tier carries a Class 3 recommendation, explicitly indicating that an ICD is not indicated and would likely cause more harm than good.
We want to avoid putting hardware in these patients.
We really do. This group consists of entirely asymptomatic patients who exhibit only a drug-induced type 1 pattern. These are patients whose resting ECGs are perfectly normal, they have never passed out, and they only show the Brugada morphology when actively challenged with a sodium channel blocker in the EP lab. For these individuals, the annual event rate is extraordinarily low, quantified at less than 0.5%.
This brings us to a crucial, deeply counterintuitive point embedded within the JCC seminars and the AHA guidelines that we must emphasize. It is a concept that goes against our standard clinical instincts. We are taught that family history is everything in genetics. But in Brugada syndrome, family history alone does not predict individual risk for clinical events.
This is a concept that requires extensive empathetic counseling to convey to patients and their relatives. A patient may present to your clinic with a profound, terrifying family history of Brugada syndrome. They may have a sibling or even a parent who suffered sudden cardiac death at a young age.
And they are understandably terrified.
Completely terrified. But if that patient in front of you is entirely asymptomatic, has a normal baseline ECG, and lacks a spontaneous type 1 pattern, their individual statistical risk for an arrhythmic event remains very low. The psychological burden on these families is immense. The assumption is understandably that the genetic curse is uniform, that if my brother died from this, I am equally doomed.
But the data just doesn't support that.
It doesn't. We must clearly articulate that inheriting the genetic architecture does not automatically relegate you to the high-risk category.
Imagine the heavy psychological toll on these families. You have to sit down in the consultation room and explain that genetics is not destiny in this specific context. But how do we synthesize all these moving parts? The ECG patterns, the presence or absence of syncope, the fever responses into something actionable.
It's too complex to just eyeball it.
Exactly. Standing at the bedside, relying solely on clinical gestalt is dangerous. This is where objective scoring systems come into play. We now have access to validated clinical tools, most notably the Brugada risk score model. This is a primary prevention clinical risk score designed specifically to synthesize these disparate clinical features into a cohesive, actionable metric. It acts as a much-needed objective anchor for you, the clinician, when you are trying to weigh complex variables.
The statistical performance of the Brugada risk model is highly instructive. When applied at a 10% risk threshold for predicting arrhythmic events over a 5-year period, the model achieves a sensitivity of 71% and a specificity of 80%.
Let's break those numbers down for everyday practice.
Yes, let us analyze what those numbers actually mean for your practice. A sensitivity of 71% means the model will correctly identify roughly 7 out of 10 patients who will go on to have a severe event. But it also means it will miss nearly 3 out of 10.
Which is a sobering thought.
Very sobering. A specificity of 80% means it is fairly good at ruling out high risk in those who truly are low risk, minimizing unnecessary interventions. What this demonstrates to you, the practicing clinician, is that while we have robust tools that offer strong discriminative ability, risk stratification in this syndrome is still a matter of calculated probability rather than absolute certainty.
We are playing the odds, essentially.
We are. Tools like the Brugada risk score are invaluable because they force a systematic quantitative assessment of variables, helping to mitigate our own cognitive biases when we are tasked with making life-altering decisions regarding permanent device implantation in otherwise young, seemingly healthy patients.
This pursuit of prognostic certainty inevitably leads us to one of the most heavily debated and controversial areas in cardiac electrophysiology, which is the role of electrophysiology studies, or EPS, utilizing programmed ventricular stimulation. If the clinical scores leave us with a margin of error, why not just test the heart directly?
It seems logical on the surface.
It does. The current AHA, ACC, and HRS guidelines assign a Class II recommendation for EPS in asymptomatic patients who present with a spontaneous type 1 pattern. A Class I recommendation essentially translates to may be considered, which reflects a deep divide in expert opinion. Let's break down the procedure itself.
The mechanics of it are straightforward.
Right. The goal is straightforward in theory. Electrophysiologists introduce catheters into the heart, advance them to the right ventricle, and deliver precisely timed electrical extrastimuli. They are essentially pacing the heart rapidly and dropping in extra beats to see if the myocardium can be coaxed or forced into a sustained arrhythmia like ventricular fibrillation.
And this raises an important question. Why does the role of EPS remain so deeply controversial across the expert consensus? The friction lies entirely in the interpretation of the resulting data and its actual predictive value in the real world.
Let's look at the evidence.
To understand this, we must look at the comprehensive pooled analysis of 1,312 Brugada patients. This robust dataset revealed that patients who had inducible arrhythmias during an EPS carried a hazard ratio of 2.66 for future clinical events.
That's a significant jump in risk.
It is. This statistically significant increased risk was specifically noted when arrhythmias were induced using single or double extra stimuli, which is a less aggressive stimulation protocol than using triple extra stimuli. On the surface, a hazard ratio of 2.66 suggests that the test is a highly meaningful prognosticator. If you induce an arrhythmia, their risk is nearly tripled.
Wait, let me stop you there and play devil's advocate for the listener. A hazard ratio of 2.66 sounds highly significant. If I'm a physician looking at that data, my instinct is to trust the EPS. If pacing the heart reveals an underlying vulnerability, shouldn't we use that to guide our ICD placements? Why are we marginalizing a test that yields a hazard ratio of 2.66?
That is exactly the argument made by proponents of EPS. It's a very compelling point. But the clinical application of that data requires deep scrutiny of the test's negative predictive value.
The other side of the coin.
Precisely. We have to ask, what is the actual clinical utility of a negative test? If you stimulate the heart in the EP lab and fail to induce an arrhythmia, does that guarantee the patient is safe from sudden cardiac death?
I think we both know the answer to that.
The categorical answer is no, and that is the critical insight you must internalize. A lack of induction during an electrophysiology study does not guarantee a low risk of future events, especially if the patient already possesses high-risk clinical features.
This is a vital concept. We are talking about the difference between the artificial environment of the lab and the reality of the patient's daily life.
Precisely. If your patient has a spontaneous type 1 pattern or a documented history of syncope, their baseline clinical presentation inherently overrides the negative results of the EPS. The biological substrate of Brugada syndrome is incredibly dynamic. It fluctuates with autonomic tone, temperature, and metabolic state.
The EP lab is a controlled snapshot.
It's just one moment in time. The fact that the myocardium refused to fibrillate under the artificial, highly controlled conditions of the EP lab on a given Tuesday afternoon does not mean it will remain stable when the patient experiences a massive vagal surge during a gastrointestinal illness or a high fever months later. Clinical presentation comprehensively trumps the EPS test results.
As the physician managing this case, you must weigh this evidence carefully. You are essentially balancing the binary output of a machine's electrical stimulation, the EPS, against the complex longitudinal clinical history of the human being in front of you. The overwhelming consensus of the literature, and the reason for the weak class IBOB recommendation, is that in Brugada syndrome, the clinical story is the paramount guiding force.
The history dictates the path forward.
Exactly. The spontaneous ECG manifestations and, most importantly, the history of syncope carry far more prognostic weight than whether or not a catheter could induce an arrhythmia on a single day.
When our comprehensive risk stratification confirms that a patient is indeed at high risk, we must turn to the ultimate safety net. The implantable cardioverter defibrillator, or ICD, remains the singular, definitively proven therapy capable of completely preventing sudden cardiac death in patients with Brugada syndrome.
It is the definitive backstop.
The implementation of this technology is guided by strict parameters based on the risk tiers we just discussed. As we establish, the Class I indications encompass the highest risk cohort: survivors of a previous cardiac arrest, patients with documented spontaneous sustained ventricular tachycardia, and patients exhibiting a spontaneous type 1 pattern combined with a recent episode of syncope presumed to be due to a ventricular arrhythmia.
There is no debate for those patients. They get the device.
These patients absolutely need a device. Conversely, the guidelines explicitly outline who should not receive this invasive therapy. Under Class 3 indications, ICDs are strongly not indicated for entirely asymptomatic patients who only demonstrate a drug-induced type 1 pattern, nor are they indicated for patients whose sole risk factor is a concerning family history. The risk of device complications outweighs the benefit in these low-risk cohorts.
Let's unpack this from a longer-term management perspective. The ICD is a miraculous piece of technology. It watches the heart rhythm continuously. And if ventricular fibrillation occurs, it delivers a massive jolt of electricity to reset the system. It saves the patient's life.
It does exactly what it's engineered to do.
But what happens when this therapeutic strategy encounters severe complications? What happens when a patient with a properly indicated ICD begins experiencing recurrent, agonizing shocks? The psychological trauma and the physical toll of an electrical storm on a patient are absolutely devastating.
It is one of the most horrific things a patient can experience.
Imagine being a young patient, fully conscious, and repeatedly receiving a high-voltage shock to the chest because your heart keeps slipping into an unstable rhythm. When the machine we install to save their life becomes a source of profound, repetitive distress, how do we escalate our clinical intervention?
When the primary safety net deploys too frequently, it indicates that the underlying electrophysiological substrate is highly unstable. We can no longer just rely on the ICD to shock the patient out of the arrhythmia. We must intervene at the level of the substrate itself to prevent the arrhythmia from starting.
We have to go upstream.
Exactly. The guidelines provide clear secondary interventions for these highly complex traumatic scenarios. Pharmacologically, the medication quinidine is the absolute agent of choice.
Let's delve into the pharmacology of quinidine because it perfectly illustrates the pathophysiology of the disease. Why quinidine out of all the antiarrhythmic drugs available?
It comes down to the cardiac action potential. Quinidine possesses unique properties that affect the transient outward potassium current, which is known electrophysiologically as the ETO current.
The ETO current is the key player here.
It really is. In Brugada syndrome, the fundamental problem is a severe electrical imbalance during phase 1 and the early phase 2 plateau of the action potential, specifically in the epicardial cells of the right ventricular outflow tract. The inward sodium current is pathologically weak, and the outward ETO potassium current is prominent and unopposed.
So you get the severe voltage gradient.
Yes. This causes the epicardial action potential to collapse prematurely, creating a massive voltage gradient between the epicardium and the endocardium. By potently blocking the ETO current, quinidine essentially removes that unopposed outward flow. It restores the delicate balance of currents, effectively smoothing out the repolarization abnormalities and propping up the action potential dome. This prevents the phase 2 reentry that triggers the lethal arrhythmias.
It is a brilliant pharmacological fix, but pharmacology has its limits, and quinidine has significant side effects, including gastrointestinal intolerance and its own potential for proarrhythmia. Beyond pharmacology, we have advanced structural interventions, specifically catheter ablation.
This is a truly fascinating area of electrophysiology.
It is. The target for this procedure is highly specific. Electrophysiologists seek out and ablate abnormal epicardial areas located specifically in the right ventricular outflow tract, or RVOT. But why epicardial? Most standard ablations for arrhythmias, like SVT or atrial fibrillation, are performed on the endocardial surface inside the heart chambers. Why must they go to the outside of the heart, the epicardium, for Brugada?
The mechanics of that ablation procedure are directly tied to the underlying embryology and pathophysiology we discussed earlier. The expression of the transient outward potassium current, the EDO current, is physiologically much higher on the epicardial surface of the right ventricle compared to the endocardium.
So the epicardium is intrinsically more vulnerable.
Precisely. Therefore, when the sodium channels fail in Brugada syndrome, the resulting electrical collapse and the arrhythmogenic substrate are localized almost exclusively to the epicardial layer of the RVOT. By carefully navigating a catheter to the epicardial surface, often requiring a subxiphoid puncture to access the pericardial space, electrophysiologists are directly addressing the localized area of the myocardium, where the highest degree of electrical dispersion and instability resides.
They are going right to the source of the storm.
They use radiofrequency energy to destroy that specific abnormal tissue. This effectively neutralizes the arrhythmogenic source, calming the electrical storm and drastically reducing the burden of appropriate yet traumatic ICD shocks for the patient.
Moving from the highly specialized environment of the cath lab back to the general inpatient ward, the emergency department, or the primary care clinic, we must address what is perhaps the most practical and immediate concern for our listeners. This is the critical issue of hidden triggers.
This is where everyday medicine meets Brugada syndrome.
The day-to-day lifestyle and medical management of a Brugada patient relies heavily on an extensive do-not-touch list of pharmacological agents and physiological states. There are numerous specific triggers that can fatally unmask the Brugada phenotype, tipping a stable, completely asymptomatic patient into a lethal arrhythmia.
This is where everyday clinical practice intersects with deadly consequences. The contraindications are broad and span multiple classes of common medications. First and foremost are the Class IC antiarrhythmic agents, such as flecainide, propafenone, and procainamide.
These are powerful sodium channel blockers.
Yes. In a disease fundamentally characterized by mutant, underperforming sodium channels, administering a drug that further blocks those channels is the equivalent of pouring gasoline on a fire. It can rapidly induce ventricular fibrillation.
Let me paint a picture of how this happens in the real world. Imagine an exhausted internal medicine resident covering the floor at 3 a.m. A nurse pages about a patient with severe nausea or perhaps agitation. The resident, trying to manage the symptom quickly, reaches for a common medication, completely unaware that the patient has a subtle, undiagnosed Brugada pattern on their chart.
That scenario is exactly what keeps experts awake at night, because the risk extends far beyond cardiology drugs. We must be hyper-vigilant regarding psychotropic medications, particularly tricyclic antidepressants like amitriptyline, mood stabilizers like lithium, and antipsychotics like trifloprazine.
Drugs we use all the time on the medical floors.
All the time. Furthermore, common anesthetics and analgesics, including bupivacaine, procaine, and the widely used induction agent propofol, pose a severe documented threat. Even certain over-the-counter antihistamines, excessive alcohol consumption, and illicit substances like cocaine can dramatically unmask the ECG pattern and trigger catastrophic events.
So what is the clinician supposed to do?
For you, the prescribing clinician, the mandate is clear and uncompromising. You must continuously consult and cross-reference the comprehensive, regularly updated database available at www.brugadadrugs.org before administering any new pharmacological agent to a patient with known or suspected Brugada syndrome. You cannot rely on memory for this list. It is too extensive and the stakes are too high.
Alongside those pharmacological threats, we must deeply analyze an incredibly common yet remarkably dangerous physiological trigger, a simple fever. We are all used to treating fevers as benign symptoms of infection, but the pathophysiology linking elevated body temperature to sudden cardiac arrest in Brugada syndrome is a masterclass in molecular biology, and it is something every pediatrician, ER doc, and hospitalist must understand.
The foundational defect in many Brugada patients involves mutations in the SCN5A gene, which encodes the NaV1.5 cardiac sodium channels. These specifically mutated channels exhibit a terrifying phenomenon known as temperature-dependent dysfunction.
Temperature-dependent dysfunction. Walk us through that.
Think of the NaV1.5 channels as a series of complex, microscopic electronic gates embedded in the cell membrane. Under normal physiological temperatures, they open rapidly during phase 0 of the action, potential to let sodium rush into the cell, initiating the heartbeat. However, as the core body temperature rises during a febrile illness, the increased thermal energy physically alters the structural conformation of these mutant proteins.
The heat literally warps the gates.
It literally warps the gates. This leads to accelerated inactivation. The gates snap shut far too early, causing a profound, critical reduction in the inward sodium current.
This microscopic channel failure cascades incredibly fast into a macroscopic clinical disaster. Because that sodium current is diminished, it fails to overpower the outward potassium currents in the epicardium. This exacerbates the transmural dispersion of repolarization in the right ventricular outflow tract.
You lose the electrical homogeneity of the ventricle.
You now have adjacent areas of heart tissue recovering electrically at drastically different times. This creates the perfect, highly unstable electrophysiological setup for phase 2 reentry, which is the immediate precursor to the initiation of polymorphic ventricular tachycardia or ventricular fibrillation.
This threat is particularly acute and terrifying in vulnerable pediatric patients. A child with an undiagnosed SCN5A mutation might contract a standard everyday viral illness, a rhinovirus or influenza. As their temperature spikes to 39 or 40 degrees Celsius, those mutant sodium channels fail en masse.
And a routine pediatric visit becomes a code.
Exactly. What should have been a routine sick visit rapidly and inexplicably escalates to a full cardiac arrest in the emergency department. The clinical application of this pathophysiology is absolute. The literature and the guidelines mandate that aggressive antipyretic therapy is non-negotiable for all febrile patients with Brugada syndrome.
You cannot take a watch-and-wait approach with fevers in these patients.
As a clinician, you cannot casually monitor a low-grade fever in these individuals, hoping the Tylenol kicks in eventually. You must actively, aggressively, and continuously suppress that fever with scheduled acetaminophen and ibuprofen to protect the structural integrity of their sodium channels.
And this physiological principle extends seamlessly into the realm of sports cardiology and endurance exercises. Athletes diagnosed with Brugada syndrome face unique challenges. They must take extreme, highly calculated precautions to prevent hyperthermia.
Because exercise mimics the febrile state internally.
Engaging in prolonged exertion, particularly running marathons or playing sports in warm, humid climates, can naturally raise the core body temperature significantly. If that core temperature reaches a critical threshold, it can induce the exact same catastrophic temperature-dependent channel dysfunction as a systemic infection. For these athletes, the prevention of hyperthermia through cooling strategies, hydration, and environmental awareness is not just about athletic performance. It is a vital, non-negotiable, life-preserving component of their daily management.
As we synthesize the immense wealth of information we have covered today, from the JCC-focused seminars to the comprehensive AHA guidelines, the core clinical mandates for you and your inpatient teams become brilliantly clear. We have tracked the diagnostic criteria, establishing firmly that only the type 1 Brugada pattern is definitively diagnostic, while the type 2 and type 3 patterns remain merely suggestive and require further investigation.
We have navigated the highly complex, high-stakes mathematics of risk stratification, learning that a rigorous clinical history, and specifically the presence of arrhythmogenic syncope, is the absolute most critical inflection point in determining a patient's trajectory and device candidacy.
We have deeply evaluated the nuanced, often frustrating debate surrounding electrophysiology studies, concluding that the patient's longitudinal clinical presentation must ultimately dictate your management over the isolated results of an EP lab stimulation protocol.
Finally, we have explored the absolute necessity of ICDs for our high-risk patients, the fascinating epicardial mechanisms of RVT ablation for those suffering from recurrent shocks, and the mandatory relentless vigilance required regarding contraindicated medications and aggressive fever reduction.
If there is a single, unifying, central message for you to carry forward into your clinical practice from this deep dive, it is the paramount importance of context. In our current era of immense medical information overload, where we are bombarded with scores and algorithms, clinical wisdom is not just about memorizing diagnostic criteria or citing risk percentages.
It's about seeing the whole picture.
True expertise lies in recognizing the profoundly dynamic, context-dependent nature of a condition like Brugada syndrome. It is deeply understanding that a patient's risk profile is never a static data point. It is a continuously fluctuating reality that is heavily influenced by the invisible shifts in autonomic tone, their current metabolic state, their incidental pharmacological exposure, and simply their core body temperature on any given day. Your ability to anticipate, recognize, and aggressively manage these dynamic physiological shifts is what will ultimately safeguard your patients' lives on the wards.
And as we conclude this thorough analysis, we are left to ponder a final, remarkably provocative thought that emerges directly from the constraints and the unanswered questions within our source material. The clinical guidelines are unequivocal in their assertion that family history alone does not predict an individual's risk for sudden cardiac events.
You must counsel our patients that their siblings' tragic outcome does not guarantee their own.
Yet we know with absolute scientifically proven certainty that Brugada syndrome is deeply, fundamentally rooted in genetic architecture, specifically the SCN5A mutations. This juxtaposition presents us with a profound, ongoing biological mystery.
It's the frontier of where electrophysiology meets genetics.
If the foundational genetic blueprint is shared completely among family members, what are the invisible, yet-to-be-discovered environmental factors? What are the subtle epigenetic switches, the complex proteomics, or the tiny daily physiological variables that ultimately serve as the arbiter of fate?
Why does the substrate activate in one but remain dormant in another?
Exactly. What hidden physiological forces dictate exactly why one sibling might suffer a catastrophic, fatal cardiac event in their 30s, while their brother or sister, harboring the exact same deleterious genetic mutation in their sodium channels, proceeds to live a completely asymptomatic, full life into old age? It is a question that heavily challenges the very limits of our current understanding of precision medicine, and it serves as a vital, humbling reminder of the immense complexity of the human heart. Thank you for joining us today on the Hospital Medicine Unplugged podcast, and we strongly encourage you to stay curious, stay vigilant, and remain rigorous in your daily clinical practice.